Hello, I'm Stephen Afawi from ZEISS. Today we're going to be discussing the i.Scription technology, but mainly about how it works in practice. I'm going to introduce you to two doctors that have been using the technology for quite some time now, and they're going to share with you their experiences, the good, the bad, the ugly, and just so that you can all see how it's used in practice and what to expect, and then how to hopefully implement it in yours. To my left here, we've got Dr. Evan Pritchett from Pritchett Eye Care. Thank you for joining us. And I've got Dr. Sean Coughlin from Bay Hill Eye Care. Actually, I should mention that you've got a group of practices in Nevada, mainly around Reno, and Dr. Sean Coughlin works in Florida. Yeah, thank you for joining us.
Glad to be here.
So Evan, if I could start with you, you've probably been using i.Scription the longest now. I think you were one of our first early adopters. You've been using it for well over 3 years now, I'd say, and probably done a few thousand i.Scription lenses. So when you first decided to use the i.Scription technology, obviously there was a learning curve, and you've managed to navigate the waters and between the technology and the practice and how to make it work. Can you describe for us what that journey was like for you?
I think initially, and you and I have discussed this, it was really trusting that the machine does what it's supposed to do. You know, analyze those higher order aberrations, take into account the effects of the pupil, and factored in with your manifest refraction, give you a better prescription, albeit sometimes a lot different prescription than what you may be getting with your manifest. I think the hardest, biggest hurdle was trust it. Even sometimes as much cylinder as it may give or different axis of just trusting what it would give and let your patient be, the final decision on was this good or was it not good, instead of prejudging it before they got a chance to see it, and still happens to be with some of my associate doctors the biggest hurdle.
So that leap of faith,
Yep.
How did you make it? What was the thing that you decided, like, I'm just going to give it a go?
Basically, it was, I think, discussion we've had, the technology, the research I did. I thought that, again, it filled that, one of the voids we have with manifest refraction, and that sometimes the answers from the patient just don't guide you to where you expect it to be, and sometimes you have to make that, jump by yourself. Now this technology helps us to do that, and that was it, of just saying, and I'm going to try it. I told my patients, hey, we'll try this. If it doesn't work, we can always go back and put you in traditional correction. Luckily, that's been almost non-existent at all. So,
well, that's great to hear. How did you feel then, Sean, when it came to making that leap?
Scared. Yeah, it's really took a while, and then the best way we did it, we just shotgunned it. I mean, we just basically gave it to everybody, and we overdid it. and then we had to learn. There's some that just pay attention to the warning signs that came up on the screen. When it tells you that that they're cautions. I was kind of overriding it. I was kind of hoping it was going to be the savior for everybody. I had a couple of keratocones that came in that we tried it, and it worked to a degree, but it wasn't the answer to everything. But we just tried it on everybody, and then we learned from our mistakes. So then it's okay, which patient does it seem to fit better with, and then you just get a feel for how to use it, which patient's going to work on.
So I've got a question for both of you then. So when you see a big shift in terms of, basically it's usually the cylinder and axis that'll scare you, right? So if you've got something that turns 90 degrees on you, how do you handle that when you first look at it? Do you decide to try it, or sometimes do you tweak it, or how do you approach it?
Me myself, initially, what I had done was trial frame some of those, and actually did have patients, even though it was totally different than what I found, actually did prove to like it better in a trial frame. Now, as with more experience with it, I feel pretty comfortable looking at initial scan, and if I'm at all, I'll rescan them again before they're dilated, and if it matches, then I'm very comfortable with that. If I get a different, and that makes more sense, and I may go with the second scan, and then that I would say that there was probably an error in taking the scan by the technician or the patient or a combination.
So can I assume that you're doing a second scan just to confirm that the measurement was right?
Correct.
So just to double check, because you had that big change. You're like, so let's check it. And then if it makes sense, if it's reproducible, you're like, okay, let's go with it.
Do you use that on when the cautions come up? Do you double do it again?
No, I really, now I've got to where I feel kind of in tune with it, and to me, if it doesn't set well, as soon as I put the drops in, I'll send them back pre-test and say, here, run another scan real quick, and then I'll let them, I'm still, have already made the recommendation on i.Scription, they're choosing their frames and lenses and so forth, and then the optician will show me the 2 scans, and then I will decide which one I think matches, or if they're very close, it doesn't matter. But
So how do you approach the trial frame? Do you do a visual acuity check, or are you trial framing anything at all?
I'll pretty much put it in a phoropter, and I'll kind of spin in the dials, because it's just for the time, and just kind of see if they really don't like it. If you turn it 15 degrees and add a diopter and a half in the cylinder, and they start squawking, well then, okay, maybe that's where I don't do it. But for the most part, it just go by feel, it seems like.
So when you have a patient that has had that big change, and you've double checked and you're like, okay, it makes sense, you go with it. And because of the large change sometimes in both sphere, cylinder, and even axis, what's the communication you have with them? Do you set a different expectation with i.Scription patients at all?
I would say initially I did, because again, I didn't have the experience and was, basically I think I was protecting myself and telling them, oh, if you have a problem, come back. Now I don't. I basically, we'll tell them about the studies, the percentages, and what the recommendations are, and stand behind it. And again, I still will tell them, hey, if this doesn't work, we have other options. So, give us some time and see. And like I said, we have very, very, I don't know exactly what the remake rate is, but it's very small, remake or non-adapt.
Would you say the remake rate is the same as traditional lenses? Is there any difference, or even less for you?
Maybe even less.
I'd say less, yeah.
Yeah.
It seems like it now.
Yeah.
After I stopped just giving it to everybody, in realizing that, that it wasn't the perfect fit for everybody. Once you realize that the people that it works for, it really works for, you get a big jump. And I have one of the staff members, one of my opticians, was a hardcore competitor's lens. And I couldn't, for the life of me, could not get her ever out of.
Which we won't mention the name.
That's right. Anyway. That's why I said that the other guys. And we put her on the i.Scription, and now she loves it. And now she's sold. So she's my biggest salesperson now.
Well, to dive in a little bit more into that question of who's a good candidate, I know at ZEISS we've tried to create an easier way for you guys in terms of like a red light, green light kind of approach. And no matter what we do in terms of looking at the data, trying to figure that out, because of such a subjective nature of stuff, it's almost impossible to do that. And something scientifically, mathematically could all look right, and the simulations look great, but sometimes they still won't adapt. Like, it's hard to have a definitive answer, yes or no. And so how do you decide who's a good candidate right now? What's the criteria in your mind when you're thinking, okay, I'm going to prescribe i.Scription to this patient? What's your criteria? Yeah.
Basically, right now, is my biggest criteria is if there's pathology, corneal scarring, ectasia, cataracts, PSC cataracts, things like that is throwing off the information to me. That's really the only patients I just exclude right off the bat. And even some of the cones and some of the pellucid and things like that, I will still, if in those, I'll put in the phoropter, like I said, spin dials, and if it's like, hey, this improves it, I'll go with it. But people, with dense, PSC cataract or other opacifications, things like that, those are usually the people. For the most part, the rest of them, what I do is I suggest it. I try it and let them see. I rely a lot on the simulations also, for patient. If it looks identical and there's no change in the simulation at all, then that may be that person. I say, and you might not be that big of a significance. It's certainly not going to hurt, I don't think, but it may not be as big a change.
So when you say simulation, do you look at the PSF? Is it what you're looking at? It's interesting. So many doctors gravitate towards different simulations, and we've been showing everyone the Zernicke analysis in terms of showing a patient how much their measurement can change between night and day. But it's interesting that you've gravitated towards the point spread function. Interestingly, that simulation is probably the most realistic in terms of monocular, and you can see both eyes, where the other simulations we have, the scenes will only show you the most aberrated eye. So yeah, that's interesting. So when you see any improvement in that PSF, for you that's an improvement. That's our Scription Candidate.
Yep.
That's
Well, and I think that it goes back to, I don't know if it was a study or maybe it was even your opinion, that really that everybody is a candidate other than those certain patients that should potentially do better with i.Scription than not. And I still today, I think that some of those non-adapts, I still go back to maybe it wasn't a very good scan.
okay.
Did they just not, did the technician not get everything lined up? Did they move slightly? Something changed, and that threw off the scan.
So when you do the second scan, do you go by the second?
I will go by, to be on now, I think I have a feel for it, and I look at my manifest, and I look at the scans, and I will choose what I think. And most of the time they're pretty repeatable, but sometimes when they are way different, I typically am going to choose the one closer to my manifest.
Okay.
Yeah.
That makes sense. And most patients are going to move towards the habitual, right? They're always going to prefer that.
Yeah.
There's no chance you're overplussing those non-adapts? I'm joking. There's no chance.
Nope.
That's cool. Is your criteria pretty much the same now as well?
Yeah, I look at the analysis, and if the numbers on the bar chart is off, then I'll start. I start mentioning it. Do you have trouble at night?
So that prompts you to ask.
It prompts me to ask it. And we still try to I do the i.Scription on everybody, and then see if it works in the optical. See if if what I say in the exam room translates to actually open up their wallet. So that I give the opticians a chance to talk a little bit more about it from there. But for me, it's when the numbers or the bar chart comes off and it looks like it's going to make a difference. That's when I usually just go right there.
If I think about some of the non-adapts then you've had, the patient comes back in, you just go straight to the manifest? Would you remake? No?
My protocol is I refract them, scan them again, and typically I will remake an i.Scription again once, and then if they're not adapt second time, then I'm taking them out of i.Scription.
That makes sense. So then how often does that happen, do you think?
Not even 10 times for me, for my own patients. I can't speak for some of the other doctors in the practice, but
not even 10.
Very, very.
And you've done a few thousand, I'd say, by now.
I think 3+ years worth of.
That's incredible.
Yeah.
I would expect a non-adapt rate similar to what you'd have of your traditional lenses, but the fact that you've had less, that's incredible. That's great. How have you handled patients that might return?
It kind of just depends on the case. I don't have a standard protocol. It's just if it sounds like you're just joking around, if they are overplugged, if it's something as simple as that, then okay.
There's a bit of truth in every joke.
Yeah, I know. We just throw the minus a quarter over top of it. All of a sudden, everything's better, and then I'll just do the math and do it that way. Keep the same i.Scription, but just with a quarter less. If their complaints are just all over the board, where it just it just doesn't fit right, well then that's the one I'll usually go back to the manifest on. It's just kind of case by case, patient by patient.
Why are doctors reluctant to prescribe a lens product from the chair?
To me, it doesn't make sense because I do just the opposite. I consider that lifestyle dispensing, and I don't sell anything in our practice. Everything's prescribed. So all of our recommendations are prescribed recommendations because we think it's going to enhance their vision, their symptoms, their environment, whatever. Whether that be a certain index material, a design of a lens, a coating on a lens, protection, whatever the case may be. It's a prescription that I'm recommending to the patient. It's part of that prescription. So I don't think I sell anything in my practice. It's all prescribed. Now, when they get out and if they want to buy sunglasses, if it's a plain old sunglasses, maybe that's a purchase. It's just something being sold. But we really look at it as more prescribed.
I think
devices.
that's the best
Yeah.
way to look at it. Do you feel the same?
Well, I feel the same too, and that's, I guess, what we were just talking about is when it's your practice, it's a whole lot easier for you to be able to do that. When it's not taught at school, and it's school, you seem to be taught, you know, the medical side of things, and the retail thing just kind of happens, and it's a learned process. And if you don't have, I think, you know, skin in the game to where it's your practice in your bottom line, and it affects you, you know, that's where I learned. You know, I spent 9 years in, you know, the corporate world where, you know, whether they bought something or it didn't, you know, it didn't really bother me. It just, you know, I was just doing refractions. Once it became my practice, now all of a sudden it makes sense. Now I know how it affects the end run.
Yeah.
How'd you escape the corporate world? Can I take some notes? You're both self-employed.
Yeah.
I like it. I admire that. That's cool. So another question then. Has i.Scription made it easier for you then to be able to prescribe from the chair? Is that something that i.Scription's brought to the table that's helped?
Yeah, it's the next best thing, and you know, we've always tried, at least with my practices, to have the best toys that are out there, the best products to offer the patients, and this is just the next best thing. So now it's easy. It's just, you know, we've always done it, so it's kind of the mindset. If we go back to contacts, you know, we do, you know, almost 70% of dailies, because that's what I feel is the best way of doing things. So my patients have, you know, come to expect that. So when I come in, I talk to at least established patients. It's pretty easy. They know that this is the best stuff out there.
Yeah.
If you truly believe in the technology and really want to show it to your patient, at least the first time. Now my patients, you know, it seems like once they've done i.Scription, they do it every year. So the second year is easy. I don't have to talk. I just show them, oh, it's still better, and off they go. But the initial first patient, you have to manage your time to knowing that you need to take time to explain this to them, or it's not going to be successful.
That's a good thing that you bring up, because a lot of doctors have asked, it's like, is this going to take longer? How much longer is it going to take? They question whether they have time to do this. So how much extra time does it take you in an exam for you to do the calculation, look at it, assess it, discuss it?
2 to 3 minutes probably. It's not like I'm losing the exam.
But that feels like a long time.
Sometimes feels like when you know you're like, oh, here I'm already
Yeah.
10 minutes behind, and trying to catch up on your schedule, patients waiting. Yeah, I mean, but it doesn't truly affect the overall way I would schedule patients on a day. I just know that, you know, I'll make it up. You know, maybe I talk a little less about something else because I know I'm going to have to explain that.
So the next question is it worth the time?
Yeah.
What'd you say? Yeah.
Oh, easy. Yeah.
Yeah. So just a few extra minutes.
Well, I think you can tell in those patients who, once they've done an i.Scription, that's there. You know, they're not going someplace else and getting. I mean, unless I guess they budget changed dramatically where they could not do it, they're going to come back and get an i.Scription, or at least in my experience, going to come back and get it again. So I think that speaks volumes for the technology.
I actually remember something you said to me once. I remember after 1 year of you having the technology, and I was asking, hey, Evan, how's it going? And you said to me, well, the patients are kind of come back now, so I'll tell you in a few months. And I remember after those couple of months, you told me a few of them were requesting their same prescription. They're like, I want to have, and that for me was a turning point for you. Was it? Is that how you felt about that?
Yeah, I mean, once you had that, I mean, you know, obviously if you're not seeing remakes, you're thinking, well, it must be working. But if you're not truly seeing those patients until, you know, they're coming for their annual exams, and then you're hearing their testimonials on, you know, oh, it's like ZEISS Vision. And I think I told you about the one patient in particular. And I mean, he always bought new glasses. He just never wore them. I mean, he bought individuals. He'd come in, oh yeah, these are brand new. I didn't wear them. The i.Scription was the first pair he came in wearing. And he says, first pair of glasses I ever wore. Wow. He goes, I put the other ones on to read, but I wouldn't wear them even though you told me I should. But he truly came back. And to this day, I just saw him a few weeks ago, and he's now in his, I think, third pair of i.Scription.
Oh, that's great. That brings up another thing. Have you got some examples or some patients that come to mind as well where without i.Scription, you probably wouldn't have arrived at that correction, where the wavefront optimization definitely took you in another direction? Does anything come to mind? Have you got any patients that you can think of where that's happened, where it was a big shift and you prescribed it?
Yeah, I think there was I had initially one of those, there was like 60 degrees different on the axis. And I'm like, how can this possibly work? And again, trial framed and, like, wow, it did. I mean, I would have never, ever gotten there in a manifest refraction. I mean, no way. And it did. And now to this day, that patient this is the way the correction is, the lady. And then the other gentleman I spoke of, again, having, what you felt like was you're doing a good refraction. Why aren't you wearing your perfect 2015 in the exam room? Why aren't you wearing this in real life? And until that,
they just don't feel right. And it just makes them feel. I tell the patients, half of what we do is science, half of it is art. And the art part is how does it feel? And and the science part is here's the technology, but you put it on, and if they have that oh wow moment, and they kind of like my staff member I was telling you, she griped about her glasses all the time, constantly, and she finally put these on, and it was wonderful. It was a game changer.
Another question then, sometimes there's patients where the shift is so big for them between night and day. Like I've seen some patients where you measure them and there's over a diopter change. Have you had much experience with prescribing a nighttime pair specifically for people that want their correction's so different between night and day?
I don't think I purposely meant to do that. But I have patients now who come back and they say, and they're not wearing their glasses, and I say, when do you wear them? Oh, they're perfect at night. I wear them every night when I'm driving. And so I think that those are people who kind of figured it out for themselves. I didn't purposely say, here, I'm just going to give you this pair to wear at night. But some have found that out for themselves.
That's better for them.
For that very small, those people that you refract and they're plus quarter, minus quarter, and you're like, and then the i.Scription gives them a half adapter here or 3/4 or whatever, and you're like, okay, and then they end up loving it, or especially in low light environments.
How do you feel that ZEISS has been in supporting you as a partner? Is that partnership worked well for you in terms of the brand, the technology?
You guys are fantastic.
You're happy with the support that you've received?
Yeah, we call, and if something doesn't work, we call, and there's a person answers the phone, and it's being fixed within 15 minutes. Where sometimes you go and you're on hold for an hour with other places, or this is down and you have to wait for them to call back. You guys are awesome.
Oh, that's great to hear. So, was there anything that you would pass on to a new doctor? Like you just got the equipment, starting to prescribe by Scription. Is there anything you would recommend they do or don't do?
I would recommend two. One, I would actually look at your scan, look at the results, look at the refract results from the eye profiler. First, just look at it and say, does this make sense to you? And if you do, then get out of your own way. Prescribe it if you don't see a reason not to, and then let it prove, it'll be successful. The only way it won't is if you don't give it a chance.
I like that, get out of your own way.
I just follow the guidelines that come up. That was my biggest mistake, was just overriding your warning signs. And I said, okay, well, it's got to be good because it's the newest technology. But you put the warning signs in there for a reason. So trust you did your job properly, and so I can do my job properly. And that was the biggest thing. And then just go with it. Just start giving it to people.
Trust it, absolutely.
It's interesting. When we first launched it in the US, one of the things I remember trying to re-emphasize a lot was it's not for everyone. And unfortunately, it seems like most doctors' first inclination is to help the patients that were maybe not happy before, or people that you knew that you wanted to do more for, I should say. You want to be able to help them. So you call up all your problem patients and you bring them in, and then there's always going to be some issues with them anyway, because you're not going to please everyone. But it's interesting how everyone's first inclination is to go for all the problem patients. I suppose you want to help them, right? And that seems to be one of the traps that some of the early adopters will do. They'll just do it on everyone when it's, sometimes you've got to be careful.
I think it goes back to the cones, and I think it was the very first day that you were even there installing it, and sure enough, I came through and I had 2 cones the very first day that it walked in, and I'm thinking, well, let's give it a whirl, but just don't do it.
Did you know there were cones, or what, did you find out from Atlas? Did the topography help you diagnose them?
One was a new patient, and I think they didn't know that they were a cone. They knew something was not right, but I don't think they officially had the diagnosis. But it was, the atlas helped, and then, so then let's try the i.Scription. I think we retried it. And the other one was an existing patient that came through, but it was just ironic. That was the first day, you don't see a cone for 3 months, and all of a sudden I got 2 of them in the first morning I'm there.
You did?
Yeah, it was tough.
Wow.
I was waiting for some of those, the softball to be lobbed at you so you could, and those 2 crazy ones come through.
I talk a lot about the wavefront optimization in i.Scription, but the topography is such a big component. Yeah. Do you look at the topography of every patient?
I don't look at it on every patient, but I look at anybody who's not refracting very well,
Okay.
or is why aren't you 20/20? Before it was always like, okay, now I'm going to run a field or OCT. Now I go right to Atlas. Is the first thing I look at is Atlas. If someone's not correctable to 20/20 and I can't determine why, let's look at the cornea first. And then before it was you weren't, if you didn't have a corneal topographer, or before we did, but it was a separate machine, then you're having to schedule them back. Now it's right there at my fingertips.
It's interesting, as everyone starts to go towards the medical model, it seems like everyone just starts at the back of the eye these days.
Yeah.
And it's nice when someone starts at the front and works their way back and looks at the optics. Yeah.
Just don't be afraid of it. Just embrace the technology, and that's the biggest thing. And just keep going, keep prescribing them, keep plodding along, because eventually you get the feel for it. You know how it works, but you just, if it sits there and is collecting dust and you're using it just for the topographer, you're never going to get the other. You're never get the inside.
And I think the thing to add to that is, and I think that's what some of the doctors like in our practice who they just throw it in there. Look at your data. I mean, before you say, is this good or is it bad, or like, wow, that doesn't make any sense. Well, maybe it didn't. Maybe it was the scan. Don't be afraid to repeat a scan. Reinforce to yourself that, hey, I did 2 scans and the results come out the same. Okay, you got to feel comfortable trying it. But I think sometimes people just forget it, that it's actually gathering all this data and they're just throwing the numbers in there and getting a calculation. Well, here's your prescription. No, look at it and the Zernicke analysis, look at your point spread simulations and look at the data and compare it to what you refracted, compare to what maybe they were wearing, and mesh it all together.
It makes sense. I've often, when I've worked with a practice and looked at some of the measurements or scans where it's shown a different result or something else outside the norm, usually there's a reason, right? There's always a reason. Mm-hmm. And then it's just trying to uncover why. And sometimes when you do try to uncover that reason, you discover a pathology. It could be an opacity issue or some kind of corneal irregularity that throws that scan off. And I've lost count the number of times I've just gone, hang on, this doesn't make sense, and you might want to have a closer look at this eye. It's interesting.
What's interesting sometimes, and I'm sure you're experiencing, my technicians will come in, I think this person has keratoconus, or they're diagnosed from looking at the scan. They're going, this person has corneal something going on here, and before it was just like, I don't know, I couldn't get it, gets auto refract.
They're starting to see the pattern.
They're starting to see those things,
Wow, that's interesting. How are your technicians going with it now? Because you've had it for about 6 months and you've had it for about 3 years, so there's a different level there. So how are your techs going with it?
They're good. I hear them talking about it all the time when they're, this is our newest machine. It's going to help you get a better prescription. They kind of follow the little magnets that you guys have. So they do a pretty good job of it. So they do all the dirty work for me. So I can walk in and just, go right into the science. I don't have to start talking about what's different. So they do a very good job.
It's really nice when a practice has that process, because in my mind, even if they don't get i.Scription, but they've heard about this new technology, that's usually enough reason for them to come back to you. So that's a win. Even if they're not getting the i.Scription by ZEISS, they've gone through that process, they feel good about coming to you, and they come back. And that's a win for everyone, for sure.
It sounds like your practice similar to mine. Patients expect it.
Yeah.
They expect when they're coming in, if there's something new in the field, they're expecting to see it at your practice.
Yeah. How's that impacted you?
It's where we're up. And we're up, and it's a good place to be, and I can point to it. So it's helped me. Our lens sales are up, or the total sales, the price, average per patient, are up, all based off of the technology.
How have you felt the impact?
Yeah, I think it's obviously it's just another thing. It's another bell or whistle to add to your premium product already. But I think that one of the more important things is kind of ignoring the financial end, I think it truly makes you a better practitioner. You're finding things, having Atlas right at your fingertips, being able to, sometimes you have those patients come in and go, well, these glasses just don't work, and they're 2015. You're like, what do you mean they don't work? They're 20. Well, now you can explain those things. Right. So I honestly think that it truly is kind of like having OCT technology in your practice, having things like that. You're a better practitioner, in my opinion.
And what would you say about the actual technology itself?
If they're interested, I'd say embrace it. I mean, it's the ways to differentiate yourself between everybody else that's out there. When I'm trying to say that with the patient, I break it down to, I used to be able to refract you down to 25 cents, but now I can get it down to the penny. We're not having to round, something to put it in their terms. But I think it's a tool for you, and it allows you to do things a whole lot better than you could in the past.
Success is really when the patient smiles, and if the patient's smiling, your staff are happy, you're happy. I'm happy.
Exactly.
That's awesome. Well, thank you very much for your
time.
Thank you very much.
Evan. Thank you.
Thanks, Sean. Appreciate it very much. For more information, please visit www.zeiss.com/equipment.